Hello, my name is Sharon, and in this scenario, I'll be a psychiatric nurse practitioner working in an outpatient mental health clinic. Today, I'll be discussing how I will handle a psychiatric crisis with one of my patients, a 45-year-old male with a history of major depressive disorder and a prior pornography addiction, now experiencing a severe situational crisis following his wife's infidelity and separation from his children. He presents visibly distressed, expressing hopelessness, increased alcohol use, job impairment, and clear suicidal ideation with a plan to shoot himself. In this discussion, I'll walk through how I would conduct a risk assessment, ensure immediate safety, communicate therapeutically, and coordinate an appropriate treatment plan. So, to begin with, I would do an immediate risk assessment. The first step in managing a psychiatric crisis is to perform a comprehensive suicide risk assessment. Given that the patient has expressed active suicidal ideation with a specific plan to shoot himself and means he has access to a firearm, situation qualifies as high risk and emergent. I would assess using the Columbia Suicide Severity Rating Scale, the CSSRS, or the Ask Suicide Screening Questions, ASQ toolkit to structure my evaluation. I would explore his intent. Does he truly intend to end his life, or are those thoughts passive expressions or distress? His plans and means. Does he currently have the firearm accessible? Has he taken preparatory actions? Time frame. When does he intend to carry out his plan? Protective factors. He mentions his children as the only thing keeping him from acting, which suggests a fragile but present protective factor. Risk factors. He has multiple: male gender, middle age, recent relational loss, social isolation, alcohol misuse, job stress, and long-standing major depressive disorder. His alcohol consumption of at least a six-pack nightly compounds impulsivity and worsens depressive symptoms. The combination of acute loss, impaired judgment, and firearm access places him at imminent risk of self-harm. So it's step two for him would be to ensure safety and legal ethical action. At this point, my primary responsibility is patient safety. I would not allow the patient to leave the office unsupervised. Because he meets criteria for imminent danger to self, I would initiate an emergency involuntary psychiatric evaluation under Tennessee Code annotated 33-6-402. This statute authorizes emergency admission when a person has mental illness and poses a substantial likelihood of serious harm to themselves or others. I would explain to this patient compassionately, I can see how much pain you're in, and my main concern right now is keeping you safe. Because you've told me you've had thoughts of shooting yourself, I need to arrange for you to be evaluated in a safe setting where you'll have 24-hour support and protection while you are stabilized. I would contact emergency services or a mobile crisis team to arrange transport to the nearest inpatient or crisis stabilization unit. Simultaneously, I would ensure removal of lethal means. If the firearm is at his home, I'd ask whether a trusted family member could secure it or if local law enforcement needs to intervene safely. Before transfer, I would document his statements verbatim regarding suicidality, my risk assessment findings, the actions taken to secure his safety, notifications made, such as the crisis team or law enforcement. So then, step three would be a therapeutic communication and de-escalation. In crisis situation, therapeutic communication is essential to maintain rapport while ensuring safety. I would use a calm, validating tone. I might say, you've gone through a devastating betrayal and the loss of your wife and children feels unbearable right now. It makes sense that you're feeling hopeless and lost. You've been trying hard to rebuild your life, and this feels like it's been taken away again. This type of reflective listening helps the patient feel heard and reduces emotional arousal. I would avoid offering quick solutions or minimizing his pain. Instead, I'd emphasize hope and partnership. Right now, you don't have to face this alone. We're going to help you through this safely, and there are people who specialize in supporting individuals in crises like this. I'd also avoid confrontation regarding alcohol use in this moment, since immediate stabilization takes priority, though I'd acknowledge it as part of the plan later. Step 4 would be a crisis stabilization treatment plan. Once the patient stabilized in an inpatient setting, treatment can proceed on multiple fronts. For one, medication review. He's currently on citalopram or Celexa 20 milligrams daily. While this may have previously controlled his depressive symptoms, the current crisis may require reevaluation. I would consult with the inpatient team about possibly increasing the SSRI dose or considering an adjunct therapy, such as mirtazapine for sleep and appetite or an SNRI for apathy and energy, since they are prominent. Medication adjustments would occur under careful supervision once his safety is assured. The patient's nightly drinking significantly increases suicide risk. Once stabilized, I recommend substance use evaluation and motivational interviewing to encourage sobriety. Referral to dual diagnosis therapy or an intensive outpatient program could follow hospitalization. Upon discharge, referral to individual psychotherapy focused on grief, trauma, and rebuilding self worth would be appropriate. Cognitive behavioral therapy, CBT, or interpersonal therapy, IPT, can help address distorted thinking and loss adaptation. Before discharge, I'd ensure a collaborative safety plan is developed, identifying triggers, coping strategies, and supportive contacts. I'd also provide the 988 suicide and crisis lifeline intervention. For follow up care, I'd arrange a follow up appointment within 1 week of discharge. Given his vulnerability, early and frequent check ins would be vital. I'd also encourage ongoing contact with a trusted member or support system. Documentation, I would thoroughly document this encounter. I would document the patient's presentation and quotes related to his suicidal ideation, structured risk assessment and findings, actions taken, such as the hold initiation, firearm removal, emergency referral, coordination with the crisis response team, follow up plan, and I would also communicate with his primary care provider and therapist to ensure continuity and avoid fragmentation of care. Collaboration within the interdisciplinary team, psychiatry, counseling, nursing, and possibly child services ensures comprehensive support. To summarize, this case illustrates how quickly a psychiatric crisis can emerge from situational stressors in patients with chronic mood disorders. My approach centers on comprehensive suicide risk assessment, immediate safety intervention and legal hold, empathetic therapeutic communication, inpatient stabilization with medication and psychosocial support, thorough documentation, and interdisciplinary collaboration. By intervening decisively yet compassionately, we can protect the patient's life and lay the foundation for long term recovery and reconnection with his family. As a psychiatric nurse practitioner, our calm presence, clinical skill, and ability to balance empathy with firm safety boundaries are essential tools in crisis care. And that is the end of the first scenario. The second scenario is in this video, we'll discuss how to manage an acute psychiatric crisis involving a young woman who's presenting with a new onset psychotic symptom in the postpartum period. This scenario raises urgent safety concerns for the patient and her infant, and it illustrates the importance of rapid recognition of postpartum psychosis, appropriate escalation of care, and family collaboration. So today, we're seeing a 19-year-old married woman at her fourth appointment outpatient visit. She delivered a baby 2 months ago. She presents differently than baseline, more provocative dress, heavy makeup. She begins talking rapidly about aliens with tangentiality and loosening of associations. She appears to believe her baby is an alien and that she needs to take the baby to the desert and leave it on a mountain. She's planning a camping trip. She denies suicidal or homicidal thoughts. Her husband reports 2 to 3 weeks of behavioral change and expresses fear about leaving her alone with the baby. Her symptoms: rapid speech, delusional thinking centered around the baby, bizarre belief that the infant must be returned to aliens, behavioral changes, poor insight, disorganized thinking. They're highly concerning for postpartum psychosis. It's a rare but life threatening emergency. Postpartum psychosis typically emerges within the first few weeks to months following the delivery and can be associated with manic or psychotic features. Importantly, even when a patient denies suicidal or homicidal intent, the presence of florid psychosis places both the mother and the baby at significant risk for harm. Therefore, her denial of suicidal homicidal thoughts does not reduce the level of concern given her delusions regarding the infant. So, her immediate priorities are number one, ensuring the safety of that baby, and number two, ensuring the safety of the patient. And number three, initiating emergent evaluation and referral for inpatient care. So remain calm, maintain rapport, and avoid challenging her belief directly, as this could increase agitation. Instead, I would use a reassuring, grounded approach to keep her engaged. So, an example of something I may say to her is, "Thank you for sharing these thoughts with me. I can tell this feels very real, important to you. Right now, my priority is to make sure that both you and your baby are safe." Because she has expressed plans to take the infant somewhere remote based on delusional beliefs, this constitutes immediate risk, even in the absence of stated violent intent. So, for patient and infant safety, do not allow her to leave the clinic with the baby. That is one of my first goals. She is actively psychotic and discussing plans that pose a direct threat to the child's safety. The husband's concern further corroborates her risk. I would initiate an emergency voluntary psychiatric evaluation, hospitalization under state mental health statutes, because she poses a substantial likelihood of harm to the child and potentially herself. Her delusions regarding the child, poor insight, disorganized thinking, and planned behavior necessitate emergent inpatient evaluation. We're going to involve that husband as a safety partner. He is reliable, present, and concerned. And I may ask him, "I need your help ensuring your baby stays safe while we arrange further care." He can help keep the infant physically safe while we initiate this transfer. We will call emergency service or mobile crisis. I would contact EMS, mobile crisis, to transfer her to safety to the nearest ED or psychiatric facility, and I would continue monitoring her in the clinic until help arrives. I would not allow her to leave to get ready for the trip or any other reason. The risk is immediate. Notify Child Protective Services because there is a clear risk to the infant. I am ethically and legally obligated to notify CPS. The action is not punitive. It ensures the child's safety during the maternal hospitalization. Other considerations would be a medical psychiatric workup, such as a postpartum workup to rule out organic causes, such as a thyroid disease, infection, substance abuse. That would include maybe drawing some labs, a possible toxicology report, psychiatric evaluation for medical initiation. Most cases, though, do require hospitalization, often with antipsychotic medication. Some examples might be olanzapine or risperidone, mood stabilizers if bipolar presentation is suspected, possible consideration of ECT if severe or medication resistant. Breastfeeding consideration, medication decisions consider breastfeeding status, though safety takes precedence over lactation preservation. The safety plan for the infant. In coordination with CPS and the spouse, the infant will remain with another safe adult while the patient undergoes stabilization. Outpatient treatment is unsafe at this time because the postpartum psychosis can worsen rapidly and unpredictably. Untreated cases can result in suicide or infanticide. Inpatient care is standard of care. It is important to preserve rapport and reduce distress. Avoid arguing about delusions. I might say, I hear you believe the baby has a special purpose, and we want to make sure both of you stay safe. We're going to have you seen by a team who can help you with these overwhelming thoughts. Maintain a calm, supportive tone, acknowledging distress while guiding the patient to a controlled environment. I would document thoroughly appearance, behavior, speech changes, exact statements about aliens and planned desert trip, mental status exam, husband's report of weeks of abnormal behavior, risk assessment, infant safety interventions, rationale for emergency hospitalization, CPS notification, communication with the EMS and care team, and good documentation is good for continuity of care, safety, and legal protection. This case illustrates a psychiatric emergency consistent with postpartum psychosis, requiring swift recognition and involuntary hospitalization to protect both the mother and the infant. The key steps included identifying psychosis and risk to the infant, ensuring that neither parent nor infant left the clinic, initiating emergency evaluation and transport, notifying CPS, coordinating inpatient stabilization. So, as a nurse practitioner, early recognition and timely action can save a life, preserve family stability, and support recovery. Care must remain compassionate, collaborative, and safety centered. Thank you very much.